The most powerful control system you possess is the one you never consciously command. Just think about that for a second. You spend your whole life deciding to move your arm, deciding to speak, deciding to look left or right. But while you're busy with all of that, all those surface-level decisions, there is a silent commander operating in the background, regulating your existence. Every single second.
It's the operating system that's running underneath the user interface you're familiar with. We're talking about the autonomic nervous system, the ANS. And honestly, just calling it a system almost feels like an undersell.
It does, doesn't it?
Yeah. It's the physiological architecture of being alive.
And that's exactly what we're doing a deep dive into today, that architecture. We're synthesizing insights from the heavy hitters Ganong's review of medical physiology and Guyton and Hall's textbook of medical physiology. Now, usually when people hear autonomic nervous system, their brains just jump to a toggle switch. Stress on, stress off.
Right. Fight or flight, rest and digest.
Yes, exactly. The classic binary.
Which is, it's the high school biology version. And it's functional to a point, but it misses the entire elegance of how the body actually works.
Right, because when you dig into the sources, you see it isn't a switch at all. It's more like a mixing board. It's about fine-tuned dominance, nuance, and orchestration. But before we get into all that nuance, we have to talk about the sheer, violence of the speed involved here.
The speed is, frankly, terrifying if you really stop to think about it.
I was reading Guyton's section on the concept of intensity, and the numbers just stopped me cold.
Right.
He talks about how the ANS compares to the voluntary system. If I decide to run, my muscles have to warm up, my coordination has to kick in. It's a process.
Yeah.
But the ANS...
it's instant.
Guyton says it can double your heart rate in 3 to 5 seconds.
3 to 5 seconds. Just count it out. 1, 2, 3, boom. Your heart rate is at 140.
And it can double your arterial blood pressure in 10 to 15 seconds. Or, on the flip side, it can drop it so low you faint in that exact same window.
That is what we call physiological violence. And it's a necessary violence. If a bus is bearing down on you, you don't have time for a slow hormonal drift to kick in.
Right.
You don't have time for your metabolism to gently ramp up. You need an immediate, system-wide reconfiguration of your hydraulics.
That's a great way to put it. Reconfiguration of hydraulics. Because that is exactly what this is. It's not just getting excited. It's the body physically shunting blood, changing pressures, altering the electrical conductivity of the heart muscle itself, all before your conscious mind even fully processes the danger.
Exactly. So if the somatic nervous system, the part that moves your muscles, is the pilot flying the plane, hands on the yoke, making the big turns.
Then the ANS is the flight computer.
That's it. It's the flight computer making 10,000 micro adjustments to the fuel injection, the flap angles, the cabin pressure, every single second, just to keep the plane from falling out of the sky.
So our mission today is to crack open that flight computer. We're not just going to memorize nerve pathways because, let's be honest, that's dry and it's not the point. We want to decode the logic of the system. We want to understand how the body manages this constant trade-off between readiness, the sympathetic system, and restoration, the parasympathetic system.
And we really have to give credit to the third player right off the bat who often gets ignored in these conversations.
The enteric nervous system, the so-called gut brain.
Ganong calls it the third division. And it's just this massive network of neurons located entirely within the walls of your gut. It's so sophisticated it can actually function even if you sever its connections to the brain.
It's a mini brain for sure.
But for the sake of this deep dive, we are going to focus on that core tension between the sympathetic and parasympathetic because that's where most of the high-stakes drama is.
Okay, let's lay out the players then. We have the sympathetic division,
also known as the thoracolumbar division, based on where the nerves exit the spine. This is the system of anticipation. It's catabolic. It burns energy to create action.
And then we have the parasympathetic division.
That's the craniosacral division. This is the vegetative system. It's anabolic. It builds up resources. It repairs tissue. It digests your food. It's the business as usual system.
Now, I want to get into the wiring immediately, the architecture.
Yeah.
Because when you look at the diagrams in Ganong, there is this just glaring difference between how I decide to move my finger and how my body decides to slow my heart.
Oh, the architecture is completely different. It's fundamental.
So in the somatic system voluntary movement, it's a straight shot, right? I've got a neuron in my spinal cord. It sends one long wire, one axon, all the way to my bicep. It dumps acetylcholine, the muscle contracts. Simple, one neuron, one target.
It's a direct line, a dedicated fiber optic cable from the central command to the soldier in the field.
But the autonomic system, It's different. It has a layover. It has this thing that the textbooks call the two-neuron rule.
This is the fundamental architectural rule of the ANS. You absolutely cannot go directly from the brain or the spine to the target organ. You have to stop. There's a relay.
Okay, so walk us through that path. What does that relay look like?
All right. So you have a preganglionic neuron. Its cell body is sitting inside the central nervous system. That's the brainstem or the spinal cord. It sends an axon out, but that axon doesn't go to the heart. It goes to a relay station called a ganglion.
A ganglion being a cluster of nerve cell bodies outside the CNS.
Exactly. At that ganglion, the first neuron, the preganglionic one, passes the baton to a second neuron, the postganglionic neuron. And that second neuron is the one that actually travels the rest of the way to the target organ.
You know, when I first learned this, I thought, why? It just seems inefficient. Why put a middleman in a system that's built for such incredible speed? Why not just run a wire straight from the spine to the heart?
It does seem counterintuitive, I agree. Until you look at what happens inside that ganglion, it's not just a simple splice in the wire, it's a distribution center. And this brings us to a really key concept, especially for the sympathetic side. Divergence.
Amplification.
Exactly. One preganglionic neuron can enter a ganglion and then branch out, synapsing with multiple postganglionic neurons. In some cases, a single signal from the spinal cord can trigger 20 or 30 different fibers going to all sorts of different places.
So it turns a single whisper from the CNS into a shout across the body.
It turns one phone call into a building-wide fire alarm. And this architectural difference really dictates the function. So let's look at the sympathetic anatomy specifically, what we call the thoracolumbar outflow.
Right, coming from the thoracic and upper lumbar regions of the spine, specifically segments T1 to L2.
Correct. Now look where the ganglia for this system are located. In the sympathetic system, there is this chain of ganglia running right alongside the spinal column. It's called the sympathetic chain or the paravertebral ganglia.
They're practically hugging the spine. They're right there.
They are. And what this means is that the first runner, that preganglionic fiber, has a very, very short sprint. It exits the spine and boom, it's already at the relay station.
But the second runner, the postganglionic fiber, has a long, lonely run all the way out to the skin or the blood vessels in your arm or your eye.
Short pre, long post.
That's the rule for sympathetic.
That's the rule. But think about the implications of that chain structure. Because all of these ganglia are linked together in a literal vertical chain, it makes it incredibly easy for the body to activate a huge swath of them all at once.
You could just pull the master lever.
Precisely. This is the mass discharge phenomenon that Guyton talks about so much. When you're terrified, you don't want to just dilate your pupils but keep your gut happily digesting your lunch. You need a total system override. The sympathetic chain allows the brain to broadcast a red alert to the head, the thorax, the abdomen, and the limbs, all at the same time.
It's a shotgun blast of information, not a sniper shot.
It is. Now let's contrast that with the parasympathetic architecture, the craniosacral division.
So these nerves are coming from two very specific places. The brainstem, as part of cranial nerves, the 3rd, 7th, 9, and X, and the very bottom of the spine, the sacral segments S2 to S4.
Correct. Now, where are their ganglia? They are not sitting next to the spine. For the parasympathetic system, the preganglionic fibers, the first runners, are incredibly long. They run all the way from the brainstem to the heart or from the sacral spine to the bladder. The ganglion, the relay station, is located on, or in many cases, inside the wall of the target organ itself.
So the relay station is literally at the destination airport.
Yes, which means the postganglionic fiber, the second runner, is microscopic. It might only be a fraction of a millimeter long, so the rule is flipped. Long pre, short post.
And functionally, what does that give us? What's the advantage there?
Discrete, fine-tuned control. The parasympathetic system is a sniper, not a shotgun. This architecture allows you to, say, constrict your pupil to read a book without also slowing your heart rate to a crawl. You can stimulate saliva production for a meal without emptying your bladder.
Ah, okay. The architecture prevents mass discharge because there is no chain linking them all together. They're all individual missions.
Exactly. That makes so much sense. The anatomy really is destiny for these systems. If you want rest and digest, you want to be able to pick and choose your functions. You don't want to do all the resting and all the digesting and all the secreting at the exact same time.
That would be messy.
Very messy.
Now, we can't talk about parasympathetic anatomy without really paying our respects to the vagus nerve.
Right.
Cranial nerve X. It's a behemoth.
The wanderer. That's what vagus means in Latin, and it really does. It wanders all over your torso.
Massive. The scale of it is hard to grasp.
It carries 75% of all parasympathetic traffic in the body. 75%. It's not just a nerve. It's a superhighway. It innervates the heart, the lungs, the esophagus, the stomach, the small intestine, the first half of the large intestine, the liver, the gallbladder, the pancreas.
So if you lose the vagus nerve,
You lose the primary brake pedal for your entire metabolic and cardiovascular system. From a physiological standpoint, you lose the ability to calm down.
Okay, before we leave the hardware section, we have to talk about the one giant exception to this two-neuron rule that we've been building up, and that is the adrenal medulla.
Ah, yes, the physiological grenade.
I think most people, including me initially, think of the adrenal gland as purely part of the endocrine system, hormones, blood tests, endocrinologists. But Gannon points out that embryologically and functionally, the adrenal medulla is actually a nervous system structure.
It is a modified sympathetic ganglion. That's absolutely the best way to think of it.
Okay, unpack that for us. What does modified sympathetic ganglion mean?
Okay, so normally a preganglionic sympathetic neuron goes from the spine to a ganglion in the sympathetic chain. It synapses, and a second neuron grows a long axon out to the target.
The two-neuron relay.
Right. In the case of the adrenal medulla, the preganglionic neuron travels from the spine all the way to the adrenal gland, which sits on top of your kidney. It enters the central part, the medulla, and it releases its neurotransmitter. But the cells inside the adrenal medulla, they never grew axons.
They're like neurons that forgot how to be nerves.
In a sense, yes. They are functionally postganglionic cells that decided not to bother with a wire. So instead of sending a precise electrical signal down a dedicated line to one specific organ, they do something much broader. They just dump their chemical payload directly into the bloodstream.
So they've turned a localized text message into a global radio broadcast.
That is the perfect analogy. And that payload is, of course, epinephrine and norepinephrine adrenaline and noradrenaline. By dumping it into the blood, the sympathetic system ensures that every single cell in your body that has a blood supply gets the message. Run, even cells that don't have a direct nerve attached to them.
And this solves the duration problem too, right? Because a nerve signal, an electrical impulse, ends the moment the electricity stops, but a hormone circulating in the blood.
It lingers, it keeps circulating. This is the physiological reason why, after a near miss in a car accident, your hands are still shaking and your heart is pounding 5 minutes later. The direct neural signal is long gone, but that chemical broadcast from the adrenal medulla is still washing through your entire system.
Which connects perfectly to where we need to go next. Section 2, the chemical language. Because we have the wires, we have the architecture, but wires are useless without a signal.
The neurotransmitters. This is the code.
And for all the incredible complexity of the body, the ANS really only uses two main languages, two primary chemicals, acetylcholine, or ACHR, and norepinephrine, or NE.
Yeah, it keeps it surprisingly binary at that high level. And there's a golden rule here that really helps simplify things when you're first learning this. Acetylcholine is the universal first leg runner.
What do you mean by universal?
I mean, everyone uses it for that first step. The somatic nerve going to your bicep. It releases acetylcholine. The sympathetic preganglionic nerve going to the ganglion. Acetylcholine. The parasympathetic preganglionic nerve, also acetylcholine. Even that special nerve going to the adrenal medulla.
Acetylcholine.
Acetylcholine. The input to every single one of these relay stations is the same chemical signal.
And that's clinically vital, right?
Yeah.
Because if you use a drug that blocks the receptors for acetylcholine at these ganglionic blocker, you don't just stop one system, you crash the entire autonomic network.
You're not just turning off the lights in one room, you're turning off the main circuit breaker for the whole building.
So the real differentiation, the real choice, happens at the second leg of the relay, at the switch.
Precisely. The parasympathetic postganglionic neuron, the one at the target organ, it keeps using acetylcholine. It is cholinergic from start to finish. It's consistent.
But the sympathetic system, it switches languages mid-race.
It does. The sympathetic postganglionic neuron switches its chemical language to norepinephrine. It becomes adrenergic.
So, as a general rule of thumb, parasympathetic equals acetylcholine. Sympathetic equals norepinephrine.
Generally speaking, yes. But you know physiology. It hates a simple rule without at least one confusing exception. And for this, we have to talk about the sweaty exception.
This part always trips people up. I remember reading this in Ganong and just thinking, why would the body do this?
It is a truly bizarre evolutionary quirk. So anatomically, the nerves that go to your sweat glands are sympathetic. There's no question. They originate in the thoracolumbar spine. They travel through the sympathetic chain, and they're activated during stress. You run, you get scared, you sweat.
So by all rights, they should release norepinephrine.
They should. Logically, they should be adrenergic. But they don't. They release acetylcholine. They are anatomically sympathetic, but they are chemically cholinergic.
So it's like an undercover operation.
It really is. They're wearing the sympathetic jersey, but they're secretly playing for the cholinergic team.
Is there any reason for it? What's the advantage?
There are a few theories. Ganong mentions that acetylcholine might just be a more efficient molecule for stimulating the heavy fluid secretion that sweating requires. But honestly, the why matters a lot less than the so what.
The clinicals, so what?
Exactly. Let's think about pharmacology. Say you have a patient with terrible stage fright. They get tremors, a racing heart. You might give them a beta blocker, like propranolol, that blocks the adrenergic receptors.
So it slows the heart. They feel calmer.
Their heart is calmer, yes. But will they stop sweating profusely?
No. Because the plec glands aren't listening for adrenergic signals in the first place. They're listening for adrenocholene.
Exactly. So you can have a patient with a cool, slow heartbeat who is still absolutely drenched in sweat because the drug hits one part of the sympathetic response but completely misses this chemical exception. And it works the other way, too. If you get poisoned with something that acts like acetylcholine or blocks its breakdown, one of the first things you're going to do is sweat profusely.
That brings us perfectly to the cleanup crew. Because sending a signal is one thing, but stopping it is just as important. And there's a massive difference in how these two chemicals are scrubbed from the system.
Oh, a huge difference. And this really dictates the texture of the autonomic experience. So acetylcholine is broken down by an enzyme called acetylcholinesterase. And this enzyme is an absolute beast. It is one of the fastest, most efficient enzymes in the known universe.
It just chops up the SEM molecule in milliseconds.
Even faster, microseconds. It ensures that the parasympathetic signal is incredibly short, sharp, and precise. A muscle contracts, then it immediately stops. The heart slows for a beat, then it's released. It's very clean.
But norepinephrine doesn't have that.
Norepinephrine has a much sloppier cleanup process. There's no super fast enzyme waiting right there in the synapse. It has to be removed primarily by reuptake. The nerve terminal literally has to suck it back up like a vacuum cleaner.
And if it doesn't get sucked up?
Then it just drifts away. It diffuses out of the synapse and into the bloodstream.
And once it's in the general circulation?
It just keeps working on any cell it bumps into that has the right receptor until the liver or kidneys eventually find it and break it down.
Yeah.
And this right here is the physiological reason why calming down takes so much longer than getting scared.
That is profound. The chemistry itself dictates the emotional timeline. Fear is instant because of the neural discharge, but the recovery is slow because the cleanup mechanism for stress chemicals is inherently less efficient than the cleanup for our maintenance chemicals.
We are chemically wired to hold on to stress longer than we hold on to relaxation. It's a survival mechanism.
Okay, let's move on. Section 3, decoding the signal. We've got the neurotransmitters, but as you always say, a key is totally useless if you don't have a lock.
Receptors. This is where all the magic happens. This is where modern medicine lives. If you understand receptors, you understand how we can manipulate the body with drugs to save lives.
Let's start on the cholinergic side. The receptors listening for acetylcholine. There are two main families, nicotinic and muscarinic. And yes, for the listeners, they are named after nicotine and muscarine from mushrooms because those are the substances first used to isolate and identify them.
Right, so let's look at nicotinic receptors first. I think of these as the gateway receptors. They are found in the ganglia at that relay station between the first and second neuron.
And how do they work mechanically? What do they do?
They are what we call ligand-gated ion channels. It's a very direct mechanism. Think of a gate on a hinge. Acetylcholine, the ligand, binds to a spot on the receptor, and that binding physically causes the gate to swing open. When it opens, ions, mostly sodium, rush into the cell.
That sounds incredibly fast.
It's instantaneous. It's a direct electrical to chemical to electrical transfer. This is why that relay station works so well without adding a significant time delay. It's a rapid-fire handoff.
Okay, now contrast that with the muscarinic receptors. These are found at the final target, the heart, the gut, the salivary glands.
These are a completely different class of machine. They are G-protein coupled receptors, or GPCRs. These are not simple gates. They are complex intracellular signaling devices.
So what happens here?
When acetylcholine hits a muscarinic receptor, it doesn't just open a hole in the membrane. It activates a little protein on the inside of the cell membrane, the G-protein, which then goes off like a little messenger and triggers a whole cascade of other reactions inside the cell.
That sounds a lot slower.
It is slower. We're talking milliseconds to seconds instead of microseconds. But it allows for something the simple nicotinic receptor can't do: complexity and nuance.
How so?
Because of this G protein machinery, the exact same chemical acetylcholine can be excitatory in one tissue, like the gut, causing it to contract and churn food, but it can be inhibitory in another tissue, like the heart, causing the beat to slow down. The G protein machinery translates the same signal into a different outcome depending on the cell type.
This is the context is king rule of physiology. The message is the same, but the interpretation changes.
Exactly. And clinically, this is the receptor we target with drugs like atropine. Atropine is a muscarinic antagonist. It doesn't affect the ganglia. It just goes to the target organs and puts tape over the muscarinic keyholes.
Okay, let's flip to the adrenergic side now. The receptors for norepinephrine and epinephrine. We have two big families here, alphas and betas.
Alpha and beta, the bread and butter of the emergency room and the ICU.
I always used to get these mixed up until I started thinking of them really simply in terms of squeeze and open.
That's a great heuristic. It's not perfect, but it's a really good place to start. Generally, alpha receptors constrict things, they squeeze. Beta receptors tend to dilate or stimulate things.
Let's drill down a bit. Alpha 1, where do we find that?
Alpha 1 is primarily on the smooth muscle of blood vessels. When norepinephrine hits an alpha-1 receptor, it triggers a G protein that causes a release of calcium inside the cell. And as you know, calcium makes muscle contract, so the vessel clamps down, vasoconstriction.
This is what explains the pallor of fear.
That's it exactly. You get scared, the sympathetic system fires, norepinephrine hits alpha-1 receptors on the blood vessels in your skin and your gut. Those vessels clamp down, blood gets squeezed out of those unimportant areas and shunted toward your core and your muscles. You go pale.
Okay, now beta receptors. Let's start with beta 1.
Beta 1 is the heart. The mnemonic is easy. You have one heart, so it gets beta 1 receptors. When these are stimulated, they make the heart pump faster, which we call a positive chronotropic effect, and harder, which is a positive inotropic effect.
So beta 1 is the heart's gas pedal.
Absolutely. And beta 2.
You have two lungs.
You have two lungs, so they get beta 2 receptors. These are found in the smooth muscle of the bronchioles, the airways. But here is the beautiful paradox of the system. When epinephrine hits a beta 2 receptor, it doesn't squeeze. It relaxes. It causes bronchodilation.
Okay, left pause here because this is a critical concept for a listener to get.
Yeah.
This is the same chemical, right? We're talking about epinephrine.
It's the exact same molecule.
So one molecule of epinephrine can hit an alpha-1 receptor on a blood vessel in the gut, and that vessel screams contract and shuts down. Then that same epinephrine molecule can float over to the lung, hit a beta 2 receptor on an airway, and that airway screams relax and opens wide.
That is the elegance of the receptor system. The specificity isn't in the signal, the specificity is in the receiver. The alpha-1 receptor is hooked up to intracellular machinery that causes contraction. The beta-2 receptor is hooked up to completely different machinery, specifically the KMP second messenger pathway, that causes relaxation and smooth muscle.
It's like sending the same company-wide email to two different departments. The legal department reads it and immediately shuts down all operations, but the marketing department reads the exact same email and launches a massive new campaign.
That is a brilliant analogy, and that principle is why we can treat asthma without causing a stroke. We can give a patient a drug like albuterol. Albuterol is a beta-2 agonist. It's designed to look like epinephrine, but it's shaped just right so that it preferentially fits in the beta-2 lock.
So it opens the lungs.
It opens the lungs beautifully, but because biology is messy and no drug is perfectly selective, at high doses, some of it will spill over and hit the beta-1 receptors in the heart.
Which is why people often get the jitters and a racing heart after using their inhaler too much.
Exactly. It's a dose-dependent loss of receptor selectivity.
I want to make this real with a story that Ganong uses in the textbook. The classic mushroom poisoning thought experiment. This is the ultimate test of your understanding of these receptors.
It's a classic for a reason. So let's say you are out foraging in the woods and you make a terrible mistake. You eat a mushroom from the Inocybe genus.
Bad idea.
A very, very bad idea. Because these particular mushrooms contain high levels of a chemical called muscarine.
So you're flooding your body with a chemical that powerfully stimulates all of your parasympathetic muscarinic receptors.
Uncontrolled, widespread parasympathetic activation. Just think about what that system does. Rest, digest, secrete. Now imagine turning that dial not to 11, but to 100.
It's not rest and digest anymore.
It's a total system evacuation. You get the classic mnemonic SLDGE. Salivation, you're drooling. Lacrimation, you're crying uncontrollably. Urination, defecation. GI distress, terrible cramping. And emesis, which is vomiting.
You're literally leaking from everywhere.
And that's not all. Your heart rate crashes into severe bradycardia, your pupils constrict down to pinpoints, and your airways fill with secretions. You are basically drowning in your own fluids.
And the antidote for this horror show?
Atropine. You need a muscarinic blocker to get in there and jam those receptors shut and stop the flood.
Okay, now let's take scenario B, a different mistake. You eat Amanita muscaria. That's the red mushroom with the white spots from Super Mario Bros.
This one is tricky because despite the name, it actually contains alkaloids that block muscarinic receptors, so it acts like a massive atropine overdose. It completely shuts off the parasympathetic system.
So you get the exact opposite of the SLUDG symptoms.
You get the classic anticholinergic toxidrome. The mnemonic for this one is, red as a beet, you can't sweat to cool off, so your skin flushes bright red as your body tries to radiate heat. Dry as a bone, absolutely no spit, no sweat, no tears, your mouth is like sand. Blind as a bat, your pupils dilate wide open, you're incredibly sensitive to light, and you can't focus on anything close up. Mad as a hatter, the blockage of muscarinic receptors in the brain causes powerful hallucinations and delirium.
It's just fascinating how removing a system entirely is just as dangerous, if not more so, than overdriving it.
Balance. The whole story of the ANS is a story of balance.
Which leads us perfectly into our next section, Section 4. The dance of dominance. This is where we look at organ-level control.
Right. This is where we put all the pieces together and see how they work in the real world.
The first concept we absolutely need to nail down is tone. Because I think people still have this mental image of the ANS as sitting at 0 until something happens.
It is never, ever at 0. If the ANS hit 0, you would be dead within a minute. There's always a basal firing rate. Think of the sympathetic nerves going to your arteries. They are firing constantly, just a little bit. Tap, 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 tap. That constant tapping keeps the vessels partially constricted, which is what maintains your blood pressure.
And this allows for what you might call single-wire control, right?
Exactly. The body doesn't need two separate nerves, one to constrict the vessel and one to relax it. If it wants to raise blood pressure, it just speeds up the firing rate. Tap, tap, tap becomes ta-ta-tapa. The vessel squeezes harder. But if it wants to lower blood pressure, it just slows down the tapping. The vessel passively relaxes on its own. It operates like a dimmer switch, not a toggle switch.
So let's look at how the two systems interact at specific organs, because sometimes they're fighting and sometimes they're actually helping each other. Let's start with the heart. That's a classic fight.
It's a reciprocal interaction. They are direct antagonists.
Yeah.
The sympathetic system, acting on beta-1 receptors, wants to go fast and hard. The parasympathetic system, the vagus nerve acting on muscarinic receptors, wants to go slow.
So it's like driving a car with one foot on the gas and one foot on the brake at the same time.
That is exactly what your resting heart rate is. Your heart's natural pacemaker rate, the intrinsic rate of the SA node if you took it out of the body, is actually about 100 to 110 beats per minute. But your resting rate is probably 60 or 70. Why?
Vagal tone.
Vagal tone. The vagus nerve is constantly keeping its foot on the brake, holding the heart back. This is incredibly efficient because it means to speed up the heart, the first thing the body does isn't stomp on the gas, it just lifts its foot off the brake.
Right. Withdrawing vagal tone gives you an instant boost in heart rate without even engaging the sympathetic system yet. Okay, now the eye. This is different. They're not fighting over the same muscle here.
No, this is a cooperative or sometimes called a distinct interaction. The pupil has two separate muscles that control its size. The sympathetic system controls the radial muscle. Think of the spokes of a wheel. When those spokes contract, they pull the iris outward.
They're opening the curtain, dilation. The term is mydriasis.
Right. You want to let in the maximum amount of light to see the threat in the dark? The parasympathetic system, on the other hand, controls the sphincter muscle. It's a circular ring, like a drawstring on a bag. When it contracts, it pulls the hole shut.
Constriction. Meiosis.
So they are two separate teams of workers pulling on different ropes to adjust the size of the same window.
And what about focusing?
Focusing is almost entirely a parasympathetic job. It controls the ciliary muscle, which changes the shape of your lens for near vision. This is why, when you are in a high sympathetic state, terrified, fighting for your life, You lose your near vision. You physically cannot read the fine print on a contract when a bear is chasing you. Your eyes are locked into distance mode by the lack of parasympathetic input.
Now, for the example that everyone remembers from medical school, male sexual function. This is truly synergistic. They have to work together in a very specific sequence.
The famous point-and-shoot mnemonic.
Break it down for us.
Point is erection. This is a parasympathetic-driven event. It requires vasodilation to allow the erectile tissues to fill with blood. And to get that powerful vasodilation, you need to be in a relaxed state. You need the rest and digest system to be dominant.
Then shoot.
Ejaculation. That is a muscular propulsive reflex. That is a sympathetic-driven event.
So mechanistically, this perfectly explains something like performance anxiety.
Completely. If you are anxious or stressed, your sympathetic tone is too high. You are in fight or flight mode. You simply cannot engage the parasympathetic vasodilation mechanism required for the point. You are biochemically blocked from physiological arousal because your body's priority is survival, not procreation.
It's a very logical safety mechanism. Don't procreate when a tiger is watching.
Evolutionary logic at its finest, and sometimes most frustrating.
I want to circle back to the adrenal dump one more time, but focus on the metabolism. We mentioned the adrenal medulla releases this cocktail of 80% epinephrine and 20% norepinephrine. Why that specific ratio? Why not pure norepinephrine?
This is a really crucial point for anyone doing a deep dive. Norepinephrine, the main neurotransmitter from the nerve endings, is fantastic at squeezing blood vessels because it has strong alpha effects. It raises blood pressure. But it's actually not that great at metabolic tasks.
But epinephrine is.
Epinephrine is a metabolic rocket fuel. It has very strong beta effects. It travels to the liver and skeletal muscle and triggers powerful glycogenolysis, the breakdown of stored sugar, glycogen, into usable glucose. It goes to fat cells and triggers lipolysis. It literally increases the metabolic rate of nearly every cell in the body.
So by mixing them 80-20, the body's basically saying, okay, we need some pressure to maintain perfusion, that's the norepinephrine, but mostly we need a massive surge of fuel to power the muscles. That's the epinephrine.
Exactly. The adrenal response isn't just about hydraulics. It's about making sure the muscles have the glucose they need to burn for the fight or the flight.
Okay, section 5. When the system fails, we always learn the most from the broken machine. Let's talk about Horner syndrome. This is a classic medical detective story.
It really is. So imagine a patient walks into your clinic. They tell you they feel fine, but when you look at them, they just look a bit uneven. One side of their face looks perfectly normal, the other side. The eyelid is drooping slightly, which is called ptosis. The pupil on that same side is tiny, constricted, which is meiosis. And if you were to touch their skin, that side of the face would be bone dry.
Anhidrosis.
The classic triad. Ptosis, meiosis, anhidrosis.
What's happened here is an interruption, a break in the sympathetic nerve supply to that side of the face.
Let's decode the symptoms based on what we've learned. Why the droopy eyelid? I thought controlling your eyelids was a voluntary action.
The main muscle that lifts your eyelid, the levator palpebrae, is voluntary, yes. But there's a tiny backup muscle woven into it called the superior tarsal muscle, or Mueller's muscle. And it is controlled by the sympathetic system. It's responsible for that extra couple millimeters of lift that gives you that wide-eyed, alert look. Lose the sympathetic nerve, that little muscle relaxes, and the lid droops slightly.
Okay, and the tiny pupil, meiosis. We just discussed this. The sympathetic radial muscle, the one that pulls the pupil open, is paralyzed. It can't pull the curtain open. So the parasympathetic sphincter muscle is now unopposed, and it clamps the pupil shut.
And the dry skin, the anhidrosis.
No sympathetic signal to the sweat glands on that side of the face. Remember our sweaty exception. It's an anatomically sympathetic nerve, so cutting it stops the signal.
So this triad is a huge red flag, it tells you. The sympathetic chain in the neck or upper chest has been cut, or more likely, compressed. And that's scary because...
Because of what might be compressing it. The classic cause is a Pancoast tumor, a lung cancer growing at the very apex, the very top of the lung. It can grow upwards and press on that nerve chain. The eye symptom is often the very first clue to the hidden lung cancer.
That is just wild. Your eye is telling you about the state of your lung.
Connectivity. It's all connected.
Another critical pathology. Organophosphate poisoning. We touched on the symptoms with the mushroom discussion, but I want to focus on the mechanism of the aging enzyme because that is just terrifying.
It is. This is the mechanism of nerve gases like sarin and VX, but also many common agricultural pesticides. These chemicals find and bind to acetylcholinesterase, that super fast cleaner enzyme, and they disable it.
So acetylcholine floods every cholinergic synapse in the body. You get the SLDGE symptoms, but also paralysis because the neuromuscular junction gets overwhelmed.
Right. But here's the terrifying ticking clock. When the poison molecule first binds to the enzyme, the bond is reversible. We can get to you quickly with an antidote drug called pralidoxim, or 2PM. It can act like a chemical crowbar and pry the poison off, saving the enzyme.
But if we wait too long,
The chemical bond between the poison and the enzyme undergoes a conformational change. It strengthens and becomes covalent. This process is called aging. And once it has aged, which can happen in minutes to hours depending on the specific poison, it is permanent. That enzyme molecule is dead forever. The body has to synthesize entirely new protein from scratch, which can take weeks.
so time is enzyme.
Literally, every minute you wait, you are permanently losing your ability to regulate your own nervous system.
Let's do one more pathology, Raynaud phenomenon. This is the one where people's fingers turn white, then blue, then red in the cold.
It's a dramatic and often painful vasospasm of the digital arteries in the fingers and toes.
And it's usually triggered by cold temperatures or emotional stress.
Right. The sympathetic signal to those arteries spikes, or the arteries themselves overreact. They clamp shut completely. Blood flow stops. The finger, starved of blood, turns ghostly white. That's pallor.
Then what happens?
The tissues that are trapped in the finger, now without any fresh blood supply, start frantically extracting every last molecule of oxygen from the stagnant blood that's left. Deoxygenated blood is blue, so the finger turns a deep, dusky blue. That's cyanosis.
And finally, the red phase.
Eventually, the spasm breaks. The local metabolic byproducts that built up during the starvation phase cause a massive reactive vasodilation. Fresh, warm, oxygenated blood rushes back in. The finger turns bright red rubor and throbs with pain as the nerves wake back up.
Now, it was originally thought to be just a simple case of an overactive sympathetic nervous system.
Right, but we now know it's more complex. It's also a hardware fault. The blood vessels themselves in these patients are hypersensitive. Even if you block the nerve, they still overreact to cold. So it's a mix of a jumpy driver, the ANS, and a really sticky steering wheel, the vessel wall itself.
Okay, final section. Section 6, integration and homeostasis. Who is actually driving this bus?
We've been talking a lot about the spinal cord and the ganglia, but they're just the sergeants and soldiers. The generals are up in the brainstem, and the commander-in-chief is the hypothalamus.
Gannon gets very specific. He mentions a key area called the rostral ventrolateral medulla, the RVLM.
The RVLM. You can think of this as the gas pedal center for the sympathetic system, located in the brainstem. It sends the constant tonic drive down to the sympathetic chain that maintains our blood pressure. If you artificially stimulate this tiny area in an animal, its blood pressure goes through the roof.
But it's not a dictatorship. It's constantly taking feedback from the body. Which brings us to the baroreceptor reflex.
This is probably the single most important reflex for your day-to-day, moment-to-moment existence. You have pressure sensors, baroreceptors, embedded in the walls of your carotid arteries, in your neck, and in your aorta. They are constantly tasting the pressure of your blood.
So what happens when I stand up from a chair?
The second you stand up, gravity pulls about 500 to 800 milliliters of your blood down into the big veins in your legs. That means less blood returns to your heart. Less blood in means less blood out. Your cardiac output drops, and your blood pressure starts to fall.
The baroreceptors in my neck sense this drop in pressure.
Immediately. They were firing at a certain rate, and now that the pressure has dropped, their firing rate plummets. This sudden silence is a signal to the brainstem that says, "Alert! Pressure is low." The brainstem responds instantly by taking its foot off the vagus brake so the heart speeds up and stomping on the sympathetic gas so the vessels constrict.
And this all happens in...
How long?
within 2 heartbeats.
Oh, yeah.
It's so fast that it catches you and stabilizes your blood pressure before your vision even has a chance to dim. Unless you have autonomic failure. Something like multiple system atrophy, or MSA.
This is a truly tragic neurodegenerative disease where those preganglionic neurons we talked about just die off. The wiring from the command centers to the soldiers starts to melt away.
So the reflex fails.
Completely. This leads to a condition called severe orthostatic hypotension. These patients try to stand up, gravity pulls the blood down into their legs, and nothing happens. The heart doesn't speed up, the vessels don't squeeze, the pressure in their brain plummets, creating a vacuum, and they just drop like a stone.
It really makes you appreciate The thousands of times a day you stand up and you don't pass out.
It is an absolute miracle of biological control engineering.
We also can't finish without mentioning the higher centers, the hypothalamus.
The CEO of the whole operation. The hypothalamus is the master integrator. It links the autonomic system with the endocrine system, controlling hormones, and crucially, it links both of them to the limbic system.
The emotional brain.
This is really the final frontier of understanding the ANS. The limbic system, your amygdala, your hippocampus, is what processes fear, memory, and emotion. And it has direct hard lines, direct connections down to the hypothalamus.
This is what explains why a simple thought can cause such a profound physical reaction.
Exactly. You're lying in bed at night, perfectly safe, warm, comfortable, and you suddenly remember an incredibly embarrassing thing you said at a party 5 years ago. What happens physically?
Well, my face gets hot. I can feel my heart start to beat faster. My stomach turns.
That is a top-down autonomic hijack. Your cortex and your limbic system processing a pure piece of information. A memory fed a signal to your hypothalamus, which then fired the sympathetic system. You had a real, measurable, physical, autonomic reaction to an event that was purely information-based.
So as we wrap this all up, let's try to synthesize it. The autonomic nervous system isn't just a simple biological thermostat.
No, not at all. It is the physiology of anticipation and recovery. It's the bridge that connects the abstract world of the mind to the physical reality of the body. It translates the concept of danger into the reality of blood pressure. It translates the feeling of safety into the process of digestion.
And understanding the receptors, the alphas, the betas, the muscarinics, the nicotinics, that is the key to pharmacology. That's how we can hack that system to treat disease.
We are essentially mechanics trying to tune a very complex engine while it's still running.
The final provocative thought that this leaves me with is this blurring of the line between voluntary and involuntary. We call it the autonomic system, automatic, as if it's completely beyond our control. But if I could deliberately think of a stressful situation and make my heart rate go up, or if people can use biofeedback to consciously lower their own blood pressure.
And where is the line, really?
Exactly. Are we just helpless passengers on this biological machine, or are we just bad pilots who haven't been given the instruction manual for this particular flight computer yet?
The yogis and meditation experts would certainly say we can learn to fly it, and the physiology suggests the connections are there. It's just a matter of learning how to access them.
For those of you who want to see the actual wiring diagrams, and you really should, because seeing the anatomy makes the function click into place, check out Ganong's chapter on the autonomic nervous system for all the cellular mechanisms, and Gaina's chapter on the topic for that beautiful systems-level integration.
Absolutely essential reading.
Thanks for stripping away the conscious mind with us today.
Gene regulated.
We'll see you on the next deep dive.